This is a case report of the oral manifestation of Langerhans cell histiocytosis. Langerhans cell histiocytosis is a rare disease of the family of histiocytosis characterized by accumulation of histiocytic cells in various tissues. The discovery of vermic granules in histiocytes of this disease and the expression of similar antigens has led to the name Langerhans cell histiocytosis. It has a relatively higher incidence in the children under the age of 15-year-old, but it can occur more rarely in adults. The etiology of the disease is still unknown, and LCH is subclassified according to the site of manifestation and organ involvement to single system LCH, lung LCH, and multisystem LCH. Single system LCH affects more the skin and bone as the most frequent clinical manifestations. Um, the clinical symptoms of LCH usually seen as secondary consequence of organ dysfunction. Skin lesion may include papules or eczematic lesions, isolated or generalized. In bone LCH, they usually suffer from pain and swelling of the affected area, sometimes fever, and the most affected bones are the skull and the jaw bones. Orally, we can notice symptoms such as gingivitis, periodontitis, tooth rotation or loss, and malocclusion. Our case today is about a 46-year-old male presented to the ENT clinic complaining of tympanic effusion and right-sided hearing loss in May 2015. He had a history of diabetes insipidus centralis of unknown etiology, which was diagnosed in 2008. Clinically, he had an exposed alveolar ridge and ulcerative granulation tissue, which was present in the region of the lower right mandible from 4.5 to 4.7 T region, and in the upper left maxilla. As you can see in the present case, the clinical presentation is difficult to be distinguished from the medication-related osteonecrosis of the jaw, RONJ, or possible neoplastic lesions. The definite diagnosis will be achieved by the histopathological examination. Due to the osteolysis of both the upper and lower jaw, the patient was transferred to the oral medicine clinic, which where they did a CBCT to determine the extent of the osteolysis. His dental history revealed multiple teeth that have been extracted by different dentists, which left prolonged or incomplete healing areas. In the ENT clinic, they did the following investigation: an 18-fluorodeoxyglucose PET CT, which showed multiple lesions in the skull, temporal bone, the mandible, and the maxilla, but no other lesions outside of the head and neck area. In MRI, the same region showed a mass in the right-sided infratemporal fossa, and erosions of the skull base and the alveolar ridges. The CBCT showed significant bone loss in the right mandible up to the level of inferior alveolar nerve. Also, in the left upper jaw, a complete resorption of the alveolar ridge was seen. Here is the 3D reconstruction of the CBCT. We can see the lower right mandible, which was completely resolved. The biopsy was carried out by the ENT department according to its critical site. It was taken from the pharyngeal recess in the right nasopharynx, next to petrous apex. They showed chronic inflammation and marked eosinophilia. At higher magnification, There was irregular nuclei in mononuclear histiocytic cells, which was admixed by small lymphocytic and eosinophilic granulocytes. They raised the suspicion. This biopsy raised the suspicion for histiocytic disorder, which encouraged them to apply immunohistochemical stain, which highlighted the expression of which highlighted different expressions of Langerhans, as we can see, uh, which consist with the diagnosis of Langerhans cell histiocytosis. Based on the extension of the disease, which was affecting the skull base, surgical intervention was not applicable. So they treated the patient with chemotherapy, cytarabine, intravenously. But prior to this treatment, 248 was extracted due to extensive perifocal bone resorption. A further PET-CT was taken 2 and 6 months after the start of chemotherapy. After that, the PET and CT were taken every 6 months. 2 years now, after 2 years after the diagnosis of the patient, he is in a good general condition with no signs of recurrent disease. The oral mucosa and oral tissues return to its um, normal shape, and here is a stable. We can see a stable lesion in the PET. No further resorption of the bone. Thank you.